button. So we are being recorded. You probably got a little icon up there in the corner. And I'm going to hand over to Mary Rose for starting off.
Okay, thanks very much, Justin. And good afternoon, everybody. And thank you for joining us at our December IUA Heads of Nursing and Midwifery Group webinar. And today's webinar is a joint DCU and UCC one. And it's the 7th webinar in the series. And just to remind everyone, the reason why we embarked on the series was to firstly mark and to highlight International Year of the Nurse and Midwife, but also to highlight the challenges that we are all encountering across all the different HEIs, and to share learnings and successes as well. So the webinars will continue into next year as well. Today's topic is academic clinical career pathways in nursing and midwifery. And this is a really important topic, and one which has been the focus of many discussions and debates that I've been part of over the last 15 or 20 years, and some of them very hotly contested debates. And the debates have centered around some recurring themes like, why should nurses do research? How much research should they do? What type of research should they be engaged with? What role should they have in the research? What type of academic attainment should they have around research? How can clinical nurses be better supported to engage with research? And what do they need to do that? Protected time, mentorship, access to research tools, academic libraries, etc. And also, how can nurses and midwife academics be better embedded in academia? And how can academic nurses and midwives be better embedded in the clinical sites? Should there be formal structures for this, and what should they look like? So we're going to interrogate some of these questions and many more, I would imagine, today as part of the webinar. As of yesterday, there was 50 registrations for the webinar, so I think it shows a huge interest in the topic, given that people are attending on their lunch break and stuff like that. So I'm delighted to present today's speakers. First up is Professor Josephine Hegarty, who's head of school at UCC. Then Professor Corina Naughton, also from UCC. And then Professor Kate Irving from our own school and DCU. And both Kate and Corina are clinical professors. And then that will be followed by a Q&A session at the end. So I'll pass over to Josephine, and thank you very much.
Thank you, Mary Rose. And I'm just going to share my screen, Justin, now. I'll just take a moment to do that. Is that working now?
That's perfect. Yep, that's working.
Perfect altogether. And I'm absolutely delighted to be here today. And this is a really important topic. And I think it's really a timely return to this topic for all of us to maybe begin to look at why this is very important and how we can maybe move along the trajectory to attaining a clinical academic career pathway and framework for nurses and midwives and allied healthcare professionals. And we have, as Mary Rose has said, discussed this a number of times over the last number of years. But I think it's really timely now in the COVID-19 context. And just as we were coming on air, we were discussing COVID-19 and the fact that we really now have an appreciation of the importance of evidence and the importance of evidence in healthcare and the importance of evidence underpinning all decisions we make in the healthcare context. Given that nurses, midwives and allied healthcare professionals make up the large proportion of the healthcare workforce, it's really timely that we look at how we can enable these healthcare professionals to engage in research and pursue a clinical career at the same time. One second, there we are. So why is research important? And I'm just introducing the topic, and my colleagues Kate and Corina are going to take over and look at the more specifics of why this whole area is very important. So there is an increasing evidence base regarding the positive benefits and the impact of research active organizations, how these research active organizations generate new knowledge and how such knowledge can impact positively on patient outcomes. We know that hospitals with greater numbers of research active clinical staff report fewer adverse events and better patient outcomes. So we're linking that research activity among clinically active staff to better outcomes for patients, which is really, really important. And there has been a shift in emphasis from research being the domain of a small number of academic institutions and a small number of individuals to the idea of more clinical academic partnerships across the health services and with individuals working in a team-based research context. But there's always a but. There are gaps between publication of evidence and the adoption of research into clinical practice. And such gaps are cited as between 10 and 17 years. And approximately only 14% of original research is ever applied for the benefit of patient care. So as a country and globally, we spend a lot of money on healthcare research, but a small portion of that actually is applied in a routine clinical practice basis. So what we need to do is look at spending more money on that implementation piece. And part of that implementation piece is looking at the research culture, looking at the individuals available in the clinical context that can support research in a clinical environment. So whilst rigorous research preparation prepares the healthcare professional for the understanding and the implementation of evidence-based practice, the reality is that outside of higher education institutions, visible and well-defined clinically based academic research career options for either nurses, midwives, or allied healthcare professional researchers are fairly minimal. The opportunities are minimal in the Irish context, and that's something we really, really need to address. And research is a central component of advanced practice roles. And in the nursing midwifery context, we're looking at the advanced nurse practitioner. It's 1/3 of their role. So however, research is part of the role, most often not realized. That could be for a number of reasons. It could be due to clinical workload, it could be due to perceived lack of confidence, lack of opportunity, lack of time on the part of the healthcare practitioner. And it's also perhaps due to a lack of priority on the organizational front, and perhaps a lack of resources in the organization that the individual is placed. So we all realize the central importance of research, but we're still not facilitating those individuals that actually have a portion of their role that ought to be research. We're not facilitating that routine implementation of that role in the clinical context. Thus, we need to really look at having a healthcare system that enables all healthcare providers to consistently deliver care that aligns with recommended best practice. And this should be one of our national priorities on an ongoing basis. Particularly now with COVID-19, we've seen how really it is important that we base every decision on the best available evidence, and we support the building of that evidence in our healthcare institutions. So I'm just going to look at this very simply, a clinical career versus an academic career. So if one is pursuing a purely clinical career, it could be as a nurse, it could be as a midwife, it could be as a physiotherapist, the training is quite clear. We know the trajectory one takes to become a nurse, a registered nurse, a clinical nurse manager, a clinical nurse specialist, an advanced nurse practitioner. We know what that training pathway looks like. Finding time and support for extra training and education can be difficult, but it's much easier to get that kind of support from the managers in a clinical context if there's a clear trajectory that says, ultimately, we're going to have an advanced nurse practitioner in the rehabilitation of stroke patients. Fantastic, very clear pathway for such an individual to become an advanced nurse practitioner. It's a faster pathway. You can get a CNS, ANP, or a clinical midwife specialist, or clinical or advanced midwife practitioner position, or a clinical nurse manager or a clinical midwife manager position by the age of 29 to 33 on average. So that's quite quick that you can attain such positions. On the academic side, pursuing an academic career, the pathway isn't as clear and there are limited positions. And it's difficult to balance clinical and research. So if one has a full-time clinical position and one is pursuing further studies, balancing the two is quite difficult. It's more difficult to get a support of managers and support of funding for the research. And it's a slower pathway. You're talking about maybe 6 years part-time to get a PhD. coping with that full-time working clinical workload and research, it's very difficult. And initially, one can actually earn less in the short term. So that's quite a challenge for us. So we know in the US, there's a massive problem in the US in terms of nursing faculty and having faculty available within the schools of nursing and midwifery to support educational programs, because the salary that one can earn in a clinical position is higher. So and it's very difficult to attain the doctorate whilst working in a clinical context. So we have an issue on the academic career front as well in terms of potential filling of posts in the longer term. So we really do need to bridge the gap between the clinical career and the academic career. So hence today's seminar. So if we're making a bridge between clinical and academic careers, how do we do that? A clinical academic is a healthcare professional who is engaged concurrently in both clinical and academic activities and can provide clinical leadership in the pursuit of that excellent base to healthcare research. Whilst acknowledging that clinical research is a key component of the role of all healthcare professionals, a clinical academic career framework helps to build research capacity and research capability to a higher level in a limited number of individuals within the workforce. So we're talking about all individuals being research aware and possibly engaging in some research, but a smaller number attaining their masters, PhDs, and going on this clinical academic career framework. And clinical academics in nursing, midwifery, and allied healthcare professionals, these individuals bring patient-focused insights to the conduction of translational research, which really offers huge direct benefits to the organizations in which they work and ultimately the service users within such organizations. So if we look at this paper that was produced by Baptiste, and they looked at the barriers for nurses engaging in research in a clinical context and barriers in an academic context. And then they looked at what the facilitators were from a clinical academic partnership perspective. So for a clinical nurse, the barriers are multifold. So you're looking at lack of time and competing priorities because you have a clinical workload and competing priorities associated with that workload. And the focus is really on providing direct patient care. There may be lack of buy-in from the organization and management and a lack of buyout in terms of time. There may be issues in terms of awareness of certain research methodologies and ability to do certain types of research. There may be a lack of resources, such as lack of access to statistics. If one is lucky enough to get a grant, the management of the grant in the clinical context is more difficult. Then if we look to the right of the screen, the academic nurse, the lack of time, and again, competing priorities in terms of teaching workloads, lack of formal collaborations and maybe clinical relationships, and the ability to engage in accessing clinical data is an issue for some individuals engaging in research in an academic context. The facilitators that these authors highlighted were that if it's a clinical academic partnership, partnerships are at organizational level, partnerships can be at the individual level. You've more likely distributed workload among the clinical and non-clinical staff because there's a recognition of the importance of the research. There's a modeling of that culture of inquiry, and it's amazing what can be achieved through that modeling of culture of inquiry, because if one sees others doing research and engaging in a clinical academic career pathway, one might then pursue that pathway oneself if one sees the benefits of it. There's a visible endorsement by the leadership within an organization of a clinical academic pathway when one sees individuals in an organization already on that pathway. And you'll see informal inquiries about education and research, and there's opportunities for one-to-one mentorship with the clinical academic in the clinical context. There's access to clinical sites and clinical data. There's also access to schools of nursing and universities and the resources around libraries, budget management, and that a wider access to experience around various methodologies. And it brings the networking and professional connection. So bringing the two together allows one to address many of the barriers that on either side are difficult if one is in either a clinical context or an academic context on its own. So this is a publication by the NHS, and they published a series of papers on Everyone Join In around research impact and highlighting the importance of clinical academic career frameworks. And these are just some pictures from that and some quotes. And they highlighted that the value of actually having a clinical academic career framework is that you're not bringing people away from clinical practice. You're encouraging and enhancing their ability to engage in their clinical practice, and also facilitating the individual to engage in research at the same time. So, and by being clinical, one sees the gaps in knowledge and the questions that need answers, and the questions that can form research questions in the longer term. That it allows staff to combine academic research and clinical activities, and managers highlighted that it attracted new talent to an organization. They also cited that having role models is key, and there's a really positive impact in terms of having clinical academic career frameworks, in that you have career pathways for clinicians and helps career progression among clinicians. And they highlighted that developing new combined clinical and research roles played a part in the wider organisation and cultural change that the NHS must go through in order to push more of its best people into doing research. And they highlighted the need for managers to release staff into research posts or clinical academic posts, because there was a huge organisational benefit associated with that. I found this framework quite helpful. It allowed me to look at the different types of pathways. So just bear with me while I take you through this. So there's a traditional clinical practice pathway, which is in orange here. So you have a registered nurse, and this was produced in the stroke context, so there's reference to stroke in this. So it's a registered nurse, and then you have the senior staff nurse, deputy charge nurse, clinical nurse specialist, advanced practitioner. So you're going from the degree to master's level, going on to the advanced nurse practice role, possibly onto a consultant nurse role, and more senior clinical leadership roles. That's the clinical practice pathway. We're quite clear in that in the Irish context, up to the advanced nurse practice role in the Irish context. Similarly, in the traditional academic pathway, we're quite clear on that in terms of you have a registered nurse, maybe they'll do a postgraduate course in a particular specialist area, perhaps they'll do a master's degree. In the current context, they'll be doing a doctorate, going on to a lectureship, a senior lectureship or a senior fellow, going on to associate professor, principal fellow, or onto a professorship role, a typical academic pathway. Then you have the other pathways that we are quite clear on. That's the leadership and management pathway. We're very clear. A registered nurse goes on to a senior staff nurse or a charge nurse, onto leading a team, onto a senior nurse manager, onto maybe a director of nursing or director of midwifery role. Very clear leadership and management pathway. We also have a practice education pathway, not as clearly defined or as used, but we have such a pathway in terms of a nurse going on to a practice assessor or a clinical facilitator role, perhaps working in a CNME, or perhaps working in a lecture practitioner type role and going on to more senior roles, not as well defined. I suppose the least well defined from the Irish context is the one in green, which is the clinical academic research pathway for nurses, midwives, and allied healthcare professionals. So you're going to talk about the nurse again after doing their BSc, maybe going on to a specialist program in their specialist area, perhaps doing a master's, and then entering a pathway where there are training fellowships to allow one to attain one's doctorate, postdoctoral opportunities, becoming a clinical lecturer, a senior clinical lecturer, onto potentially a consultant practitioner and clinical reader, or onto a clinical professor. So there's quite a clear pathway one can follow in the UK context, but that pathway isn't as enabled in the Irish context. So then if we look at the UK context and internationally, we see the idea that there are clinical academic career frameworks, and these frameworks optimize the ability of clinicians, healthcare practitioners, to maintain a clinical and academic research role. And it's an overarching structure that facilitates and benefits the workforce by promoting that clinical academic workforce as part of a consolidated approach to supporting non-medical healthcare professionals. And in the UK, I love this sentence by the Health Education England, that they have a statutory responsibility to develop a workforce that embraces research and innovation. That idea of embracing research and innovation right across the health service executive is something that we really would like to see happen, so that we change that research culture across all healthcare professionals and embrace research and innovation at every level. So this is just a picture out of that clinical academic career framework in the UK context, and they quite clearly define that you're starting off at an introductory level after a BSc, of an internship. You have an early clinical career, perhaps very limited or no research training and experience. The internship is part of the BSc in an undergraduate program. You have a research project, so attaining some exposure as part of an internship. Then normally 1 to 2 years clinical experience, and having an interest in research, one might go on and do a master's. So that's an academic training for graduates who have little formal research training and experience. Then some will go on and do a PhD, and there are formal fellowships to allow one, funded fellowships, to allow one to attain a PhD while still developing clinical skills in parallel. So it's the academic element and the clinical element in parallel. That's really important. So we're supporting the clinician, a nurse, a midwife, allied healthcare professionals to maintain their clinical role whilst also doing a PhD, and often addressing very clinically relevant problems within an organization. Then after that, there are pathways that one can pursue for postdoctoral research and having a clinical workload, developing more specialist knowledge, and having a clinical leadership role, but also having that academic clinical linkage as part of one's defined role and position. Then obviously one can do more postdoctoral training and become independent investigators, and looking at developing more advanced theory and knowledge and becoming a senior clinical leader, but also attaining a senior clinical lectureship onto maybe joint appointments at professorship level. Now in the UK, there are certain training programs and funding awards that facilitate this. So there is a pathway with associated resources and funding to support it in the UK context. So that builds capacity and capability among nurses, midwives, and allied healthcare professionals. The trouble is, it's still a work in progress, even in the UK. So overall, according to the Medical Research Council in 2017, the proportion of clinical academic nurses and midwives and allied healthcare professionals is less than 0.1% of the workforce in the NHS context. In contrast, the number of clinical academics in the medical consultant workforce is 4.6%. So we have a very long way to go in the Irish context, because we're well below 0.1%. So in the UK, there is a framework, there's a lot of investment, but they still have a long ways to go. And we know from research that was done in the same year, where they actually retrospectively analysed those who participated in the academic clinical fellowship program for doctors and dentists. It revealed that there was a positive career progression. There was this happened predominantly in translation and clinical research for trainees, and trainees would recommend the scheme to others. So it was a very positively appraised scheme. It makes huge sense to support this. The trouble is that fiction is that it makes too much sense. The reality of what we're doing at the moment doesn't make as much sense in this context. So if we were to move forward, and this is my last slide, the implementation of a framework and the sustainability of a framework requires joined up thinking between higher education institutions, joined up thinking with the health services, the research funding organisations, and the government departments of health and the government departments of education. So it needs to be concerted effort across a large number of organisations to support a clinical academic career framework for nurses, midwives, and allied healthcare professionals. And so there needs to be targeted funding to support that research awareness piece onto the clinical doctoral research fellowships, clinical lectureships, senior clinical lectureships, clinical associate professors, and clinical professors. And this should happen across the hospital groups and the CHO areas in combination with the affiliated higher education institutions. So a lot of joined up thinking in terms of funding and facilitation of this. It requires flexible working arrangements for combining clinical, academic and research work. It requires defined and well-resourced mentorship schemes to keep people on these trajectories and to really reap the benefits of these highly skilled individuals. And it requires training and education programs and funded support for individuals engaged in the attainment of higher degrees. So this is the vision for the clinical academic career framework in the Irish context. And we're going to hear more now from Professor Corina Naughton, who's going to look at the specifics of the benefits of such a framework. So thank you, and I'll stop sharing and hand over to Professor Naughton. Thank you.
Great. Thank you, Josephine. That was really insightful. So I'm just going to hopefully share my screen here. You can always never be 100% sure that you'll be able to do that.
And we have the opportunity to put in questions and answers, Mary Rose, don't we, as people go along if they wish in the comments. Yeah, so if you have a question or a comment or something you want us to address later, please put in a question or a little comment in the chat, because it's really through that conversation that we can maybe flesh this out a little bit more and begin that national conversation, because now I think the time is right for us to do this work.
Okay,
so over to you,
can you see my screen there?
Yeah, if you just want to start it from the beginning there, yeah.
Great, yeah.
It's not in slide share. Yeah, it's coming.
Great.
That's
okay.
It.
Excellent, great. So thank you, Josephine. That was really insightful. So really in my talk, what I'm going to do is build on what Josephine has said around the models, and particularly looking at the experience of the model in the UK. When I was preparing this talk, really, when we talk about clinical academic careers, or CACs as they're kind of abbreviated to, it's a little bit similar to horse racing. If you think about in horse racing, what you have, and it's the same with clinical academic careers, you have that innate talent, that person who has the passion to go that extra distance. You have the training, the expert training that prepares that person for those challenges, and then you have the mentorship and the guidance to help make that person's pathway, make that person successful. But as in everything in life, it's never really just that linear format. And we're looking here at the winner of the 1967 Grand National. And of course, the winner wasn't necessarily the fastest or best horse in the race. It was actually the horse that managed to survive all of the other obstacles. And this is what happened at one of the fences in that Grand National. They all came a cropper at this one particular fence, this one particular obstacle. And actually the horse that won the Grand National that year was one of the slowest horses in the race, but actually managed to bypass the carnage because they were able to see it. And I think that horse had 100-to-1 chance of winning the Grand National that year. And I think it's a little bit similar with clinical academic careers, even in systems that have been trying to do this for a long time. So I'm going to share a little bit of the research around the Health Education England and the NIHR Integrated Clinical Academic Programs in England. These programs have been, the funding for these integrated clinical academic programs have been in place since 2008. So they have a long history of developing these pathways, and they've invested quite a lot of resource and planning and strategy around it. It's also worth noting that as well as these national fellowships, there are also regional fellowships, and these are often collaborations between very large hospital organisations and their academic partners. Scotland and Wales also have separate funding pathways for these, so they are very well embedded as concepts within the UK. The NIHR has recently undertaken a massive review of all of their training programs. And Josephine has already alluded to this. So what the findings that were in this report is that there is an underrepresented professions in these clinical academic pathways. Medical doctors are the highest, they receive the highest number of applications for medical doctors. Dentists are the most successful in obtaining these clinical pathways. And interesting what they say about nurses. Nurses and non-healthcare professions are not so successful. For ICAs, these are the integrated clinical academic pathways, the lower success for nurses is a particular concern, given that they've been trying to do this since 2008. We have a lot that is worth learning from what they're doing in the past and are now progressing to address these deficits in the UK, in England. So following this review, the NIHR, which would be the equivalent of our Health Research Board here in Ireland, but on a much larger scale, it has to be said. But they have reorganized their clinical training, their clinical academic training through this NIHR Academy, this umbrella organization. And one of the core ethos of this organization is collaborative, multi-professional approaches to research. So really embedding that at the heart of all of their fellowships. And as Josephine has already alluded to, it is a whole system pathway from internships, the pre-doctoral, the clinical doctorate, the clinical and senior clinical lectureships. And between each of these steps, there are bridging schemes to get people from one stage to the next, and there's mentorship schemes as well. And really what this review identified, that there was a failure to progress from the pre-doctoral, which is really the master's by research level, up into the clinical doctorate. There was huge attrition among nurses and midwives at that stage. Allied health professions tended to be more successful in progressing from the pre-doctorate to the clinical doctorate. And then at the clinical and senior clinical lectureships, again, there was huge attrition. So just looking at the clinical doctorate fellowship, so this is the PhD model that they use in these fellowships, and these are individual awards. They're not awards to an organization. So you apply as an individual for these awards. Approximately 80% of the time is allocated to the academic element, and this is the undertaking of a particular clinically applied research project. 20% of the fellowship, the person remains clinically in their clinical role. They hold a joint clinical and academic contract between a clinical organization and an academic organization. These are highly competitive and very well funded programs. So it covers salary costs. They're not talking about student stipends, but the person maintains their salary, which is one of the major barriers for nursing. It covers tuition fees, it covers any of the costs associated with the research projects, and there's that your very structured clinical academic training programs. So to address that attrition rate, particularly from the master's level, what you have regionally now across the UK are these nursing and midwifery incubators. And the purpose of these are to expand the capacity and support to develop the skilled clinical academic research workforce in nursing and midwifery. And it is very targeted to nursing and midwifery. The aim is to foster a community of practice, but really kind of the real benchmark is to try and improve the progression along this integrated clinical academic program and other fellowships, and to develop and test the new models of support and professional development. In tandem with the incubator hubs, they have these clinical academic research advisory service. And one of the kind of very new innovations, and this is at a much more senior level, but it addresses that leadership piece that Josephine was talking about and role models, is they have this nurse and midwives research leadership program. It's abbreviated to 70 at 70. And that's really kind of targeting that senior clinical lecturer professorship level. Okay, so I'm just going to briefly go through some of the research around the experience from the NIHR clinical academic pathways to date. And this is a paper by Cowley et al. Recently published. And they talk about what were the values, and these were qualitative interviews with people who had come through these NIHR programs. So the goal of these programs are very clear. It's autonomous researchers that are leading, delivering, and interpreting, contributing to clinical research while continuing to evolve clinical practice and clinical expertise. So it's really this emphasis on the applied research. This paper was quite interesting. It took a critical theory perspective in terms of the lens it used to analyze the project, and really what that meant. This is the idea that a capitalist society is organized in a way that is unjust and fails to put emphasis on the power relations that serve to hinder progressive ideals. And when you apply that to the CACs, what their authors articulated were the current cultural context encourages and normalizes the ongoing intellectual development of CACs in medical and dentistry, but less so for nursing, midwifery, and the allied health professions. So just that was making explicit the lens with which they viewed the data they collected. So the two main findings from this paper was what was the impact of these clinical academic pathways for participants. So they identified the identity transformation. So particularly what you see in emerging in these individuals is this criticality. You're bringing that criticality back to their own practice. The impact on generating understanding and the application of evidence-based practice, and also development of key attributes, namely resilience, tenacity, the ability to accept and act on criticism. The second theme was the operational transformation. And this is, again, this ability to be able to critique not just their own practice, but how the service is delivered within their organizations. I think it was very interesting. One of the findings, your recurring finding, and Josephine already alluded to this, was organizations don't really know, the clinical organizations don't really know what to do with these people once they have either gone through the MRes or the clinical doctorate level. These practitioners often had to seek new opportunities outside their original host organization. And again, as Josephine has said, this access to mentors and role models was a critical factor in their being able to progress beyond particularly the clinical doctorate level. So the conclusions were that need to reconceptualize this training opportunity away from a purely commodified transactional approach of knowledge provision and acquisition. So not just looking at at research knowledge and skills, to one of personal and professional transformation, particularly a focus on the receptiveness of organization cultures for CACs. And one of the core changes that need to happen is individuals, funders, and organizations need to relinquish previous identities to establish collaborative initiatives. So I suppose really the point is, this is not just about funding. This is kind of my second last slide, so bear with us. So these are two other publications. So really, if we need to convince people to invest in this, and it is, in the greater scheme of things, it isn't a huge investment, but it is nonetheless investment in time and resources and money. So Josephine has already addressed what were the positive impacts and the opportunities. I think I'm just going to kind of focus a little bit on the challenges. So one of the challenges is the visibilities of these role models and mentors within the organization. I think another really core challenge, and it's a core challenge for all of us undertaking applied research, is the access to research funding, and the research funding to buy out the time, the protected time, as well as to deliver the research. And I think that is one of the huge barriers in clinical academics being able to continue within their role. And oftentimes the type of research that is applied clinical research in nursing, allied health professions may be less valued at some levels in society within our kind of health systems than other applied research. I think the other point that we have to be very mindful is what is the impact and how we articulate that impact. A lot of the impact around clinical academic careers is narrative and in nature. The quantitative data tends to focus on the number of publication and conference presentations And yes, from a clinical organizations, they like tweeting about these things, but actually it'll always come back to the service delivery, that transactional model. So looking at the impact of clinical academic careers at the patient and service level, just like we've had to do in the advanced nurse practice field as well. So really trying to provide that evidence of impact at clinical patient level and how we capture that. So there's a whole piece of research within the research for clinical academic careers. So in conclusion, nurse and midwifery clinical academic careers are entirely feasible. They need to focus much more at an early career. So we kind of think about, the academic piece is the piece that we do at the, once we've got all of that clinical competency model achieved. So the A&P then starting to launch into doing that clinical academic career. Really and truly, that's we're missing an opportunity. So this very much starts within our undergraduate and how we think about research and preparing our undergraduates upwards, not just thinking about it after the A&P, the person has achieved an A&P role. Funding alone is not enough, and I think that's probably one of the core learnings from the NIHR, that you need much more than just the funding available. But obviously you don't get anywhere without the funding. The clinical organization commitment. So how is it that this group of practitioners operationalize and remain within their clinical organizations? The postdoctoral funding for research, well, we could talk about that for the rest of the day, but just to say that is a huge piece of the clinical academic role. And measurable impacts. So looking at the patient and service level, not just the kind of, the traditional academic measures. So thank you for your time, and I'm going to hand over to Kate. So I'm going to stop sharing.
Hi everyone, I'm going to share my screen now. So I just happy to be here, and thanks very much for Mary Rose for kicking us off, and for Josephine and Corina doing such a good job that I now have to follow. And what I want to talk about is the opportunities that are available to us nationally that we might be able to try and harness. Now, this doesn't change the fact that I feel very strongly that as all institutions that teach nursing, we should get together and not care who gets the glory for any of this, but we absolutely need to be a united voice that professionally we argue for parity with our colleagues, our medical colleagues and dentistry colleagues. But I suppose what I wanted to say is that there are schemes available in Ireland that if we work together, we could try and harness. Now, this doesn't mean it would get us the whole pathway as it was presented there, but we could start to work with funding agencies. We could start to lobby. We could start to be more powerful as an organisation. And indeed, myself and Corina had a meeting earlier this week with the chief nurse, and there's very, very positive noises there in the new strategy. So I think there are opportunities that we were thinking before the seminar started. We might be in the right place at the right time, but I think it's going to take some joined up thinking and some joined up pressure from all of us in all of the HIAs. So there are opportunities that are available to us that we could harness. So there's the HRB. Obviously, there is the SPHERE program that many of you will be aware of and may have had students on, may have had nursing students on. But obviously it's not nursing specific, and nor would it be. And then there's the collaborative doctoral award that's available in the HRB, which normally wouldn't be profession specific. It would normally be multidisciplinary, and it would be around a particular issue such as kind of stroke rehab or dementia or a specific clinical issue, and it would be a multidisciplinary endeavor. But nonetheless, the SPHERE pays a stipend, and and the fees for a PhD. So that's for that top section of the pathway there that has been presented. And the CDA would also pay salary for some of that time as well. And it is available to nurses, but it's not going to be a nurse-only scheme. The other big opportunity for us as a national kind of, if we got together nationally and we could put forward a bid for funding from the Wellcome Trust, and that is indeed how the ICAT programme is funded, and that's a medical doctoral funding. And that's kind of the gold standard that we would love to be able to do. But again, what I'm talking about is picking off parts of this whole pathway and trying to find out ways we could fund parts of it. And what is really needed, as we've seen, is this whole approach to the pathway from early career right through to, you know, clinical professors. And then, so I'm going to talk a little bit about those schemes, and then talk about the next steps and where we're going to go, where we hope to go to from here. And really, less is more for me. I think I would really like to leave some time to answer some questions if people have them. So the Sphere is an annual training program, and its population health is its raison d'etre. It has a strong vision to provide excellent education and training, and it has really a great track record of producing really transformatory research projects in a wide range of different clinical areas and professions. And its aim would be similar to what we might endeavour to do, which is to develop research leaders. And certainly there's a lot to learn from the Sphere project in terms of, if we were trying to endeavour with a pathway, there's a lot that's really good about the Sphere programme that we would probably want to put into any kind of model that we would develop. And they take the whole, all of the universities in Ireland are members of the Sphere project. Well, in Sphere 2, if it's funded through the HRB, which it hopefully will be. And their approach is they get the best scholars, regardless, completely agnostic of what clinical area they're in or what profession they're in. They get now obviously, you know, if we look at that socio-politically, we could see that perhaps nursing isn't highly prestiged enough in terms of deciding what excellence is. That depends on the frame that you're viewing things in. And I think Corina made that point very clearly. But nonetheless, they don't have a nursing bent, they have a population health bent, and their endeavour is the best scholars, and they match them with the best supervisors for that scholar's particular issue, and they look nationally at that. And I think that's a brilliant kind of another thing we may learn if we were to have such a scheme in Ireland. The Collaborative Doctoral Award, and there is a call next year, is a patient-focused research, and it aims to support doctoral training programs where there's a school put in around a particular issue, and it's usually would be, that's meant to say allied health professionals, it usually would be multidisciplinary, and each Collaborative Doctoral Award will provide training for about 4 scholars, 4 to 5 scholars, and several of them may be able to have a stipend, and several may be able to get equivalent salary input. So that's the next step up. Again, those Collaborative Doctoral Awards are usually around a very clinically focused issues such as you know, primary care, stroke care, something more narrow than perhaps we might like to have. If we had a nursing, midwifery, allied healthcare professionals, we might want to narrow it to a particular field of health. The ICAT has it actually has 7 graduates nationally, and this is funded by the Wellcome Trust and by the Health Research Board jointly. That joint collaboration between Wellcome and HRB has since is not in the new strategies of either of those organisations. So the exact programme that funds ICAT isn't available to us. However, Wellcome do have a call in Q1 next year, which I'll talk about, and that would be available to us. So all ICAT scholars have 6 to 7 years of their full salary paid, and get to the juicy bit. And it's an absolutely joint endeavour between clinical practice and universities, and there's this graded kind of stepping out of clinical practice gently in year 1, and year 2 to 4 is almost full-time academic, and then year 5, 6, 7 potentially can be 80-20%, while people establish their clinical research careers back in clinical practice. So it's a real gold standard in terms of what we could learn for how we might be able to run a program if we were to get such funding. So let's just be clear, the Wellcome Trust do have a call next year, but the call isn't live yet, so it's difficult to find too much information about that, but it looks like we could get together. Some or all of the HEIs could get together and make a Wellcome Trust call, and I'm trying to get more clarity from the Wellcome Trust about whether that would have to be very on a specific area of health, or if that could be for all of nursing, or all of nursing and midwifery, or all of nursing, midwifery and allied healthcare professionals. I think that's possibly unlikely, given that there would only be five doctorates per year for 5 years funded, but that would be a big start. I think that would give us a step in to getting a pathway involved. And I feel like if we were able to get that funding, we may be able to leverage further funding. If we could be successful in a bid in Wellcome Trust, then we may be able to leverage further funding. So that is a big opportunity that I think I would be looking for other universities to come on board and work along with us in terms of making a bid for Wellcome Trust. In the meantime, I think, we need to carry on lobbying and talking to the Chief Nurse's Office and lobbying the HRB for equity. But in the meantime, we can't just sit waiting for our mouths to be filled with gold. We have to actually step out and do something ourselves as well. And I think that this is a very good possibility to get part of the pathway in place, and an ability to leverage further funding. So I don't want to say any more than that, because I do want to leave some time if people, I can see there's a couple of questions there. So how will I do this, Mary Rose? Well,
yeah,
I just invite questions.
If you like, Kate, I will read out the questions, and then whoever wants to jump in.
Yep.
Some of them are comments, some of them are questions. So the first one is Anthony Staines. He said he agrees with Josephine's assessment of the need for many agencies to get involved in building a pathway, and ponders who would make this happen, how would we make this happen. So maybe, Josephine, as it was addressed to you, I'll come to you first.
Thank you, Professor Staines, for a lovely question. I suppose this is something we're all pondering. We are fairly clear on the agencies that need to be involved. You need research funding agencies, you need the HSC, you need the Department of Health, the Department of Education, and we need the various nursing organisations supporting this. So I know at IUA level we have put a paper into the system around this in the past, and COVID happened. So it's part of our, I suppose, our strategy, if you like, at IUA level to pursue opportunities to push this agenda as much as possible. So certainly we at the IUA level will be advocating for this, and I know that Kate and Corina have been advocating with the chief nurse, but I think we need a concerted effort to perhaps develop that positions paper further, update it, and meet the various stakeholders individually to push this agenda as much as possible. And we also need the bottom-up approach, as Kate has mentioned, that we need to be doing as much as we can to get funding to support elements of this. But the problem is with such an approach is that we support people to attain an element of it, but then they fall at that hurdle that Corina had in terms of the Grand National, because there are a lot of barriers in their way. So we do need a concerted effort, and we need to push hard for the best possible implementation of a framework and the most supported implementation, so that we can address those barriers, and individuals who have that expertise and that knowledge are enabled to optimally function within both the health services and the higher education sector. I don't know, does that answer the question, Mary Rose?
Yeah,
Thank you, Professor Staines.
Thank you, Josephine. The next question is from Peter Carr, and he asks, how can one contribute to the document and framework from an Irish context? So anybody who wants to can jump in there.
I think through the heads of school as well would be a way. Maybe Kate, you have other ideas there?
Yeah, Corina and I said that we would report back after today to the chief nurse on whether there is whole kind of a support from the profession as a whole, you know, the academics anyway, as a whole, in terms of do people feel this is an important, I mean, I'm seeing some of the chat in the chat that this does seem to be something that people feel is a really timely thing to be done. So I think that through the heads of school we need to go if it's the case that we have support, then we need to say that to the chief nurse and say, as the heads of school of the schools of nursing, we support this initiative and we're willing to be on board, and to know that that's going to really mean rolling our sleeves up and giving this priority from our perspective as well, that this is going to take work, it's going to take partnership, which is always the messy, swampy kind of grounds that are not straight lines, lots of fences. You know, I think learning from our closest geographical colleagues, so that we don't fall at the fence, that all the carnage of the horses, and we come along and say, well, we'll take the benefits of that. And I think taking the benefits from Irish initiatives as well is really important, but all of that takes work, and it means that we have to prioritize it, and there's only so many hours in an academic's day or in a clinician's day, and we can only prioritize the time that we have.
I'm just going to kind of come in there as well. I mean, I think actually what's very, very clear in the data coming out from the UK is our clinical organizations need to want this. Mm-hmm. So our regional directors of nursing, our directors of nursing in acute community, even residential care, residential care as well. I mean, we have to get them on board with this. And actually that is the real challenge is, and I see that the comment there, there is a prioritization of get the clinical waiting list down, get the clinics through. So you're persuading a director of nursing to release people's time or to protect people's time for research. So there's a huge piece there around changing that mindset. I suppose the other piece is, valuing applied and translational research, where there's a piece of where we don't value that enough. It isn't seen as that high level research that's going to drive the economy, that's going to create the jobs. So I think there's a whole piece around really being able to demonstrate the role of applied clinical research addressing the immediate day-to-day issues in our acute community, integrated care, etc. So for me, there are two big priority areas there.
Yeah. Thanks, Kate and Corina. And so I think you've probably addressed two of the queries there, which were about managing those patient waiting lists, and they came from Martin Dignan and David Field. Lorraine Carroll has another, it's probably more of a comment, very interesting discussion. As a university lecturer, I would love to have a combined role, continue with some clinical practice, but academic workloads and commitments such as teaching, admin and research and part-time PhD means it's very difficult for me to find time for clinical practice. So again, I suppose it's alluding to that juggling that is going on for all of us, and the ever-expanding role of an academic. It used to have 3 arms and now it seems to have about 15. Any comments from the panel on that one?
I think obviously in academia we have tremendous numbers of students, and there is a very high teaching load in a nursing midwifery context. So there needs to be a resource associated with that as well to support this. So it's a wide-ranging thing. I want to come back to the comment that Martin made around the ANPs, if you don't mind, Mary Rose. The government strategically prioritised that we'd have 2% of our nursing midwifery population as ANPs, which is about 750 nurses and midwives. I think we're around 250, 300 at the moment, maybe more. And if 1/3 of the individual ANP's role is supposed to be research, that's a massive resource that's currently not being optimized and supported for their research engagement. So I think as Corina has mentioned, that whole research culture from a clinical perspective, if research is seen as something that can be shelved when there is a waiting list, or put to the side when there is a clinical need, well, then we're never going to advance. It needs to be protected time for our advanced nurse practitioners and our advanced midwifery practitioners, because they're role models in the clinical context. And if we can't get it right at that level, we're going to be in difficulty when we come to other types of roles that support clinical research and academic components. So we really need to look at that particular cohort and support them optimally. And when a person exits a program, Corina mentioned very well that in the UK there are transition arrangements, there is support in that transition out of a program. So ideally, for advanced nurse practitioners or an advanced midwifery practice or any advanced practice role, you need a transition arrangement as they exit their higher degree qualification, so that they can be supported to become those independent researchers for that 1/3 time, and to optimize the use of that resource. It's a dreadful shame that we're not supporting our colleagues in the clinical environment. There are examples of good practice, but uniformly it needs to be happening for every single ANP and AMP, that they get that protected time, because for the services it's a real reward if we could support that research. They're just thoughts. And from an academic perspective, we really do need to look at how we can support the teaching and research more optimally within schools of nursing and midwifery as well.
Mm-hmm. And then Rob O'Connor has a comment. Great conversation from the participants. Is there one extra need over and above getting the system and ambition right from undergraduate level, that being the availability of seniority of career in a clinical environment which relies on research? So, example, nurse consultant is seen in some UK locations. In other words, something that is enabled by research and gives an output for the many years of additional labour that is required to undertake serious levels of research. Kate is nodding there. So
well, I think that was in Josephine's kind of circular concentric rings of the different pathways, and how, you know, having embedded academic skill and experience and knowledge in the clinical path, in the clinical academic pathway, is what we see. That's what we've presented, Robert. I think that is what we see as a missing gap. But how we can actually get there, where from you know, the junior stages of nursing graduates all the way up to the clinical academic professor, as meaningful joint appointments, that is a gap, and we do see that as a gap. And the fact that you know, Corina and myself are trying to really rally nurses to become more research active, to get a critical mass of nurses in clinical practice who are doing research. But the big problem with that for us is that there's no draw, there's no clinical pathway that we can point to and say, look, if you do this, if you make these, in some sense, sacrifices, perhaps pay cuts, perhaps you know, taking time out of family life in order to study, as we probably all have done, that there's no pathway that's obvious for those nurses if they were to make those sacrifices. So I absolutely think that is what's missing, Robert. Yeah,
I think some of that as well has been, we just need to kind of get into a mindset where we nurture talents. It is literally, the survival of the fittest, rather than we nurture and we mind people. I mean, I suppose some of it is, we have a responsibility, our visibility. So one of the things that is very clear in the literature is that they need to see visibility, role models, mentors. So I think there's an awful lot we can do at that young early career graduate. So yes, I agree with Josephine with the A&Ps and their protected time for research. That is absolutely a fundamental. But I think to radically change the system, we need to be looking at role modeling, mentorship, early career fellowships, and really that nurturing that talent. Not everybody wants to do this, and but because it is, you are plowing a furrow that isn't conventional, and doing a joint academic clinical role is not for the faint-hearted. I think Kate and I would agree on that. But there are people who are passionate and they want to do this. They want to kind of really fundamentally believe in that evidence. So I think there's a lot we can be doing at that early career graduates that won't cost the earth, but we need to shift our mindset.
Yeah. It's 4 minutes past 2. I've got 2 more questions. I'll Josephine, do you want to come in first just before?
No, I was just going to go back to Rob's question. I think we need a nationally agreed framework that we can all buy into. So if we can support an element of the framework, we can point to that framework. So we need government support for a published framework that said this is the direction of travel to support clinical academic career frameworks for nurses, midwives, and allied healthcare professionals, and this is government policy. So therefore the HSE, the Department of Education, all research bodies can point to where we're actually addressing this government strategic priority. And until it becomes a government strategic priority to enable such a framework and such a pathway, it's going to be all of our own individual efforts, which will be good, but not enough to sustain a system transformative change. So we need a framework that government agree with.
Yeah.
Sorry, Mary Rose, thank you.
Yeah, no, I absolutely agree. And just Anthony's comment there, just wondering about PhD versus DNP. What are your thoughts?
Do you want me to take that, Mary Rose, if you want? This is a contentious issue because in the US, there's a massive move towards professional doctorates. And some of those professional doctorates have research elements and some have quality improvement elements and different kinds of thesis arrangements. And then you have the traditional PhD, which is the currency in an academic context. They both have value. In terms of the US, there are difficulties at faculty level in that the majority of universities require PhD supervision for higher research degrees. So faculty need to have PhD qualifications, the number to supervise higher research degrees. And some research organizations will only accept PhDs as opposed to professional doctorates as the currency for grant applications. So it depends on what the focus of one's career is. A professional doctorate has huge benefit in terms of that clinical senior leadership piece. But in terms of an academic research context, the currency is PhD, and I think we have to look, that is the reality of the situation. So we have to look at, the individual has to look at what their priority is. There's not one is better than the other. Some are more relevant in other different contexts. Yeah. Maybe that doesn't answer the question, Mary Rose, but
no, I think that's excellent and very well pitched. And I'm going to give the last word to somebody who appears to be clinically based person here, because it's been all the academics speaking so far. And so this one is from Ursula Nagel, who's saying, agree, as an AMP, I couldn't do research without protected time, but it's not a third of my clinical time. So Ursula, that's a very valuable comment.
Sorry, Mary Rose, I knocked Peter's question off there. I was trying to answer it online. And I knocked it off. And Peter's NUIG, and he's a come from Australia, and he's worked as a clinical lecturer over there, so he's exposure to a different system, and I think very frustrated back in Ireland now. But he was asking what's the hope for clinical practice, clinical professional careers, and I wanted to just say I think the hope is better today than at any other time. I think we are in the right time, in the right place, and I think that, you know, myself and Corina and others, if others want to join us, will lobby for this. We will lobby for this pathway. We have a vision, and a very strong vision. I think that Josephine presented a brilliant kind of overview of a vision, and I think we can go on and we can develop that vision further, and we can work it out. But it does require funding, and we are having, you know, we're in discussions, and that's not going to be, that's going to be a long racehorse. It's not a sprint.
Yeah,
but I think the hope is better now than I would have thought in previous times when I've spoken with Peter.
Yeah, thanks, Kate. And I think we should have another webinar on this topic, and next time we'll bring in people from the clinical sites to have input and say as well. I think it's really one-sided if we don't do that. So I really want to thank all of the contributors today, Josephine, Kate and Corina. Thanks a million for all your work. I know it's a lot of work to get something like this ready. Thanks a million to Justin for supporting it, and to all of the attendees. I hope everyone has a lovely, restful and safe Christmas, and thank you for all your work on behalf of the webinars this year so far, and we'll see you in 22.
Thank you, Mary Rose.
Bye bye, everyone.